If the pills don't work, and you can say, gee, I've been trying to stay flexible, but I'm getting stiff and it's painful. I took my Motrin, it's been now 6 weeks and it's still painful. That's when many times people will come in to see me in the office, and that's when we can use a different type or a more potent type of anti-inflammatory, and those are cortisone injections. And cortisone injections have a whole reputation to of themselves, and I think for the most part cortisone injections have a bad reputation. To me, the most common things I hear about from patients is, well, I don't want a cortisone, doesn't it damage the tissue? Well, I don't want cortisone, I hear it's only temporary. Well, I don't want a cortisone injection, I hear that it just masks the problem. First of all, cortisone, like any drug, can damage tissue. Just like Tylenol can damage your liver. You'd have to have a lot of cortisone injections, though, for it to damage your tissue. And we do have a rule of 3 strikes and you're out. But if you get 3 cortisone injections in a year, you're not going to damage any tissue. And also, the cortisone acts locally. So you can have 3 injections in your shoulder, you can have 3 in the other shoulder, you can have 3 in your knee, 3 in your hip. You're not have like 12 injections, you're going to fall apart. We don't like to give multiple injections in one location. First of the next, cortisone is temporary. I've given enough cortisone injections to people, and they come back a year or 2 later, and they say, "Hey, can I get an injection in my other shoulder?" I'm like, "Yeah, whatever happened to your? Oh, ever since you gave me that injection, my shoulder was fine. Can I have?" So I see enough of those patients that make me want to give more injections. Now, I certainly admit I give patients cortisone injections, and it doesn't do anything. But I know I'm not hurting the patient because I'm only going to give 1 or 2 or maybe 3 injections. But 1 or 2 injections has no downside, so I try it. And the third downside, it masks the pain. It doesn't mask the pain. Novocaine will mask the pain. Somebody breaks a bone or something like that, you give Novocaine or Marcaine, so they play in a football game, you're masking the pain. Cortisone decreases the inflammation. And since inflammation causes the pain, by decreasing inflammation, the pain goes away. Now, sometimes the inflammation comes back. If the inflammation came because you have a big bone spur we're going to talk about and you did a lot of overhead activity, well, if you decrease inflammation with a cortisone injection, your pain will go away, but because you still have the bone spur, and if you go back and you still do a lot of overhead activity, the inflammation will come back. So sometimes cortisone doesn't fix the problem. Sometimes it can only help the problem for a few months. So you try to stay flexible at home. You still have pain, you try anti-inflammatories, you get a cortisone injection, but your shoulder is still stiff. The best way, in my mind, to get rid of the stiffness is manual physical therapy. I do not believe that going to physical therapy and working on the pulleys or doing a bicycle or getting ultrasound is very beneficial in loosening up a stiff shoulder. And the reason why is because of the 2 joints. The stiffness is related to the glenohumeral joint, the ball and socket joint. So you need a therapist to hold the scapula still so that the scapulothoracic joint doesn't move. Many times people go to therapy and they say, I said, "Did you go to physical therapy?" They said, "Yes, I've been for 3 months." I said, "What did they do at therapy?" "Well, they did a lot of massage." So they did ultrasound. These are all can be effective treatments in alleviating pain, but I don't think they're effective in helping mobilize the shoulder and get rid of stiffness. So to get rid of a stiff shoulder or a frozen shoulder, you really need manual therapy, somebody putting their hands on you. And then the final thing, you have a frozen shoulder, it's stiff, it's painful, you've tried the anti-inflammatories, you tried the cortisone, you tried the manual physical therapy, you're no better. At that point, then I offer people surgery. And this is an example of surgery. The video on the left is a video of a normal shoulder joint. Okay, it's looking at the back of a left shoulder, and that probe's coming in the front. And what that probe is about to do is it's about to probe a normal ligament. And I just want you to get an appreciation for how thin the ligaments in a normal shoulder are. They're like saran wrap, a millimeter. Okay? This is a frozen shoulder who needed surgery. And what happens with a frozen shoulder, physical therapy hasn't worked, the anti-inflammatory, so I go in there and I cut the ligaments. And by cutting the ligaments, I can restore range of motion. And you'll get a little bit of an idea here comparing the normal on the left and the inflamed frozen ligaments on the right, how thick the ligaments can get from being a normal millimeter on the left to they can be almost a centimeter. Next thing, do not focus on strengthening the shoulder. I see a lot of people who come in who have shoulder pain and they say, "I've done my exercises, I've gone to therapy," and what they've done is they've aggravated their shoulder, particularly the supraspinatus. This is the second topic we're going to be talking about. tendinitis or impingement syndrome, right where that little yellow dot is, that's where the majority of shoulder pain comes from. So I've kind of moved away from a frozen shoulder. I'm now talking about a different topic. I'm now talking about rotator cuff tendinitis. And it's this tendon right here that gets the brunt of the problem, and this tendon attaches to this bone right here, and it lives underneath the acromion right above. So that tendon gets squeezed, or we call it impinged, between the two bones, and we call it impingement. The acromion is the bone on top of the shoulder blade. Between the tendon and this bone, there is a layer of tissue called bursa, which is a slimy, slippery tissue that is very thin. Again, like saran wrap. It shouldn't be thickened, but it can get inflamed. The acromion can be flat, it can be slightly curved, or it can be hooked. This is an example on the left of a relatively normal-looking acromion with a nice big space here for the supraspinatus. And on the right, this is a acromion with a large bone spur that has developed over time. And this bone spur is digging into the supraspinatus. Above the supraspinatus, there is a bursa. And then above that is the acromion. And as the arm is lifted up, the bone right here, called the greater tuberosity with the rotator cuff tendon, gets pulled up close to the acromion, and if it has a bone spur, it can dig into the bursa and the tendon, causing inflammation. So there can be a space here that's nice and big space, but when you try to lift up your arm, that space gets narrowed, and the bursa can get inflamed. These are the type of exercises that aggravate people who have impingement or rotator cuff tendinitis. Essentially, bottom line, it's weight-bearing activities above shoulder level. This is what aggravates people and can make people will come in and say, it hurts when I do bench press. It hurts when I do military press. It hurts when I do pull-ups. It hurts when I do push-ups. And it's the old adage, if it hurts, don't do it. This is one of those situations where these type of activities are aggravating the inflammation around the supraspinatus tendon from that bone spur. Here's an example of showing some therapy, and the therapist will commonly do this exercise right here, but this is an exercise right here that can aggravate any kind of problem with the supraspinatus. Here's a physical therapist with a patient saying, look how smart we are doing exercises for the shoulder. This is an exercise that will aggravate the supraspinatus and rotator cuff muscles. And here's somebody showing how strong he is, but this is a bad exercise for the shoulder. So how do I treat impingement syndrome? We try the same anti-inflammatory pills. We try a cortisone injection. We do physical therapy to make sure the shoulder's not stiff. Once the shoulder's not stiff, we cross that off the list. If you have rotator cuff tendinitis and a stiff shoulder, I treat the stiff shoulder first. If the shoulder's not stiff, then I start treating the rotator cuff tendinitis. I teach the correct exercises, and then as a last resort, we talk about surgery. So what are the right exercises to do? The right exercises are to strengthen the upper back muscles. You don't have to have a back like this, but this just shows you the area that I want to focus on. So these are good exercises to do. And the thing to notice about these exercises compared to the other is that the elbow is below the shoulder. So these are exercises to strengthen the upper back muscles. This is external rotation in the side. These are Theraband exercises. Again, notice that the elbow is below the shoulder. And by keeping the elbow down, you're not going to aggravate that supraspinatus tendon. You're not going to impinge that tendon or bursa underneath the bone. Rowing exercises are excellent for the shoulder. It helps strengthen the upper back. These are more beneficial exercises. Again, what they have in common is that the elbow is being kept below the shoulder, so you're not causing impingement. If this doesn't work, then you get to meet me and we do surgery. And the surgery I do is called a subacromial decompression, where I go in there and I remove the inflamed bursa. So this is a view in that space with the acromion is going to be up above here, the rotator cuff tendon is down below. This cotton candy is inflamed bursa. It shouldn't be like that. In a normal shoulder, it's barely visible. It's like saran wrap. So this is a nice example of somebody who has a lot of bursitis or inflammation. And once this bursa is removed, you'll see the rotator cuff tendon, which also is white underneath it. So this right over here is the rotator cuff tendon. And we just get rid of all the bursa. And eventually, after we get rid of the bursa, we'll be able to look at the acromion and notice that the acromion has a curve to it. And we want to get rid of that curve or that hook. So you get rid of the bursa as a first step, and then you get rid of the bone spur as a second step. All these surgeries are done underwater. That's why it kind of looks like those little flecks. And they're done arthroscopically, so it's like a laparoscopy for the belly. They're done with 1/4 inch, 1/2 inch incisions. Usually I make 3 incisions for this type of procedure. For rotator cuff repair, which I'm going to show next, I will make 4 little incisions. So this is how I treat inflammation of the shoulder or impingement. Now the acromion's nice and flat. We've talked a little bit now about frozen shoulders, stiff shoulders. We've talked about rotator cuff tendinitis or impingement. And the next thing to talk about are those root problems that I get nervous about, because everything up to now won't lead to arthritis. If you have a frozen shoulder, it will get better. I had a patient today, her range of motion was like, she'd get to about here, her good shoulder goes to here. She said she had no pain. And her good shoulder gets up to here, her bad shoulder goes to here. She said, what should I do? It's not going to lead to arthritis. It's not going to lead to cancer. It's a stiff shoulder. If you don't have pain, it doesn't bother you, live with it. She said, will it get better? I said, probably. This is a frozen shoulder is something that's been going on for millennia. And it probably will get better. It might take a year or a year and a half or 2. I think that going to physical therapy and getting manual therapy to stretch it out will get you better quicker. But I told her, live with it if you want. Impingement syndrome, it hurts when I reach overhead, it hurts when I do that way. That doesn't lead to any problems in the shoulder. It doesn't lead to arthritis. And so if you can live with your rotator cuff tendinitis, go ahead, do so. But when the pain gets severe, that's when I get concerned, and I want to make sure you don't have either a large rotator cuff tear or significant arthritis. So things I look for is when people come in and they're holding their arm like this, although that can be seen in a frozen shoulder. People who say they can't sleep, that's bad. Rotator cuff tears are really, really bad. And the reason why is because the deltoid now has won the battle.